Thank you, Achal Baini. Good evening, everyone. I am Seema Adhikari. Recently, I am doing my internship in Gandaki Medical College. First of all, I'd like to thank the Grey Medicos team for coming up with such a brilliant idea and hosting such informative session every week. I'd also like to thank Shabal sir for being such a supportive member. Sir has guided me throughout this presentation. Okay, now without any delay, I would like to proceed to my case. Okay, I'm going to present the case. This is a case of 56-year-old man from Sangja who attended to Gandaki Medical College emergency with a history of fall from height 20 to 25 feet approximately on 3rd of April 2021 with a chief complaint of headache, vomiting, bleeding from scalp and loss of consciousness. The patient was apparently well few hours back to the presentation. Then he presented to emergency with the bleeding from scalp. 5 centimeters laceration was there in the scalp, which was managed primarily in Sangja Hospital. Primary suturing was also done. He also complained of headache, which was severe type, which was acute in onset and severe, associated with multiple episodes of vomiting. The visitors also mentioned that he has loss of consciousness for more than 5 minutes. The patient was hypertensive and taking tablet Amlod 5 mg. He has no history of diabetes mellitus and hyperlipidemia. He has no any surgical history. There is no history of diabetes mellitus and hypertension in the family. The patient is alcoholic and smoker. He has normal sleep and appetite. There was no documented drug and allergy history. On examination, the patient looked confused. He opens his eye on verbal command. He was able to localize pain. He looked pale while other cardinal signs were absent. On measuring the vitals, his pulse was recorded 82 beats per minute, which was normal in volume, rhythm, character over the right radial artery. His blood pressure was recorded 146/92 mm of Hg. Over the right arm, his respiratory rate was 24 breaths per minute. His temperature was measured 98.6 degree Fahrenheit on right axilla, and SpO2 was 97% on ear. While doing the central nervous system examination, we have to firstly focus on calculating GCS, that is Glasgow Coma Scale. As the person opened his eyes on verbal command, his best eye-opening response was recorded 3. His best vocal response was 4, and his best motor response was 5. Right pupil was slightly sluggish and 3 mm in diameter, whereas left pupil was 5 mm and fixed. Power on right extremities was 5/5 and on left extremities was 3/5. His cranial nerves were intact, reflexes were intact, and there were no alimeningeal signs. As the patient has a weakness of left limb, he has focal neurological deficit. By taking the history, my provisional diagnosis was fall from height with moderate head injury and left anisocoria with left hemiplegia. If you have any queries, then you can please put forward your questions.
Hello, everyone. Am I audible?
Yes, sir, you are audible.
Okay. So, okay, where is Seema?
Yes, sir.
You can. Okay, let's see. So, does anyone have any question about this? So this is a unusual presentation. Most of the patient, those who have problems in head, it can be head injuries or it can be stroke. Stroke, I mean like it can be hemorrhagic stroke, hemorrhage in the brain, or ischemic stroke. So whenever there is a lesion on left side, there will be problems, there will be pupillary problems or problems in the pupil on the left side, whereas there will be hemiparesis or weakness of opposite side. But in this case, you can see the patient has bleeding from his left side of the scalp. So that means the patient had injury over his left side. And the patient left pupil is dilated. So anisocoria means unequal pupil. So left side must be dilated than right, comparing to right. So there is some insult on the left side of the brain. We know that there is some problem in the left side of the brain. But despite, so if there is left problem, if there is a injury to left side of the brain, then there should be right hemiparesis or hemiplegia. But in this patient, there is left hemiplegia. So this is not a true localizing sign. So normally, uh, if there is injury on the left pupil should dilate and the right side should become weak. Whereas if there is injury means there is a subdural hematoma or extradural hematoma or contusions or hemorrhage in the right side of the brain, then the right pupil will become dilate or unequal compared to the left, and there will be contralateral hemiplegia. So we use the term contralateral hemiplegia. So that those are true localizing signs. So these happens in more than 80% of the cases, but the rest 20% of the cases may present with something like Dr. Seema has presented, uh, unilateral pupillary dilatation and ipsilateral or same side weakness. So this is called like false localizing sign. This is not a true localizing sign, and this happens in 20% of the cases. So when any patient with head injuries who presents to emergency with low GCS or GCS less than 15, GCS less than 15, then if the patient presents with vomiting, loss of consciousness, even seizure or abnormal body movement or pupillary problem, we need to do a CT scan. We need to do a CT scan to find out what is the problem. So in this patient with provisional diagnosis of moderate head injury, so it is a case of fall from height because patient fell from height. So most of the patient either they fall from height or they may encounter road traffic accident or there might be a history of physical assault. So the first part is clear that it is fall from height. The second part is moderate head injury. So on the basis of Glasgow Coma scale, we classify head injuries into mild or minimal, moderate, and severe. We will come to that in next. I think we'll come to this later. And so there is anisocoria, there is pupillary dilatation of one side, and there is hemiplegia of the same side. So because of this, there is an indication of CT scan. So the CT scan was done. Okay, let me turn on my video too. Okay, so hello, I think you can see me now. Okay, so the CT scan was done. So you need to explain, you need to know what type of CT it is. So in case of trauma, in case of head injury, we advise for plain CT. So no need to do a contrast CT. So just a plain axial CT of head. So if it is a case of road traffic accident, then I think nowadays, uh, instead of doing X-rays of C-spine or chest and thorax, chest and abdomen, we do whole body CT. That is, if it is available, because it is very fast and we can see the problem instantly instead of taking the patient from ER to CT scan to X-ray department. So better to do a whole body CT. That will save time, and we will know what are the problems, either whether it is in head or say spine or chest or abdomen. So you can do a plain CT. So if you assume if CT of head is normal, spine is normal, there is no hemothorax or pneumothorax, and if the patient is in shock, so there might be some problem with abdomen. There might be some injuries to the abdomen. So liver laceration or splenic tear or kidney injury, then you may need to do contrast CT. So that is only the indication of contrast CT in case of trauma. So in this case, we did a CT scan of head, which showed lens-shaped opacity on the left side. So left side means, I think, uh, for you guys, I think, just remember, in CT scan, if there is a lesion on your right, like in this picture, there is a lesion on your right side of the screen, so that is actually left. So left is right and right is left when it is shown on CT scan. So in this CT scan, you can see there's a scale by the side of that down arrow, down, you can say arrow. So that arrow shows a lens shape or biconvex opacity, and that is white in color. So if it is white, we use the term hyperdense. So hyperdense or white means blurred in CT scan. Though the bone, you can see the bone, the white density around the film is also white in color. So bone is white, blood is white, CSF and air are black, and you can see the brain tissue is gray black. So what we can see in this CT scan is on the left, there is a left hyperdense biconvex lesion in the CT scan, and we need to measure it. We can measure the length and thickness of the on this CT scan. So length can be around 5 to 6 centimeter, and thickness might be around 2 centimeter. And we need to calculate the volume. So what you can learn from this class is how to calculate the volume of hematoma, because hematoma volume is very important, because whether to operate or not, whether to operate this case or not, we need volume, and we need to know the something called midline shift. So is there any midline shift? So in this CT scan, you can see two black densities in the middle of the screen. So that's two small shadows are actually ventricles, which contain CSF, and in between the two ventricles there is a small line. There is a line that is actually the septum pellucidum, that will separate the two ventricles. So if this septum pellucidum is in the midline, then there is no midline shift. But if it is shifted towards opposite side, so then we can say that there is a midline shift, and we need to measure how much, whether it is 1 millimeter, 2 millimeter from the midline, or 5 millimeter from the midline, because for treatment, for management of this case, it is essential to know whether the volume of the hematoma and the midline shift. Okay, so let's see. So let's move forward. So in this case, there is a midline shift of around 5 mm, and the volume is more than 30 ml. So why I'm giving emphasis on volume is because if the volume is more than 30 ml, or if the hematoma thickness is more than 1.5 centimeter, or if there is a midline shift of 5 mm, we need to go for surgery. So in case of neurosurgery, we use the term craniotomy or craniectomy. So whenever we use the term craniotomy, this means that we are removing the skull that is adjoining to the blood, and then after evacuating the blood, we will replace the bone with screws and plates. So that is craniotomy. But if there is a brain swelling and we cannot replace the bone back, then that becomes craniectomy, ectomy. Okay, so what we did in this case, we can proceed, Seema, we can proceed to next slide.
Okay, sir.
So so you can see, I think you can see just below the arrow, there is a small black dot. So the black dot is just at the tip of the arrow. You can see there is a black dot. So that black dot in between the hematoma indicates that the blood, there is still bleeding, there is still ongoing bleed, and it's actually called swell sign or swelling. So SWIRL. So if you see this, there is swell sign, that indicates that the hematoma is still bleeding. And in the middle part, you can see the right ventricle, the ventricles on the left side of the screen, the right ventricle, you can see it properly, but left ventricle we cannot see because it is compressed. It is compressed because of the hematoma. Okay, let's move on to next slide. So after investigating, after doing a CT scan, we can now finally diagnose this case as fall from height with moderate head injury with anisocoria. I think chorea spelling is mistake. We need to correct that. And left hemiplegia, again, there is a left hemiplegia with, now we can say it is left acute extradural hemorrhage. So why extra acute? Because the color of the blood is white. So whenever the blood is the color, whenever the whenever the density is white, we use the term acute. If it is black or darker, we use the term chronic. It is extradural hemorrhage. Why we use the term EDS? Because it is biconvex, the shape. According to shape, if it was like the shape of a moon or crescentic shape, it would have been called as subdural hematoma. So this is an acute extradural hematoma. Extradural hematoma means the blood is outside the dura mater, that is in between the in between dura and inner table of the skull bone. So skull bone have like outer table, the middle part is diploid, and then we have inner table of the skull bone. So this is the collection of blood in between the inner table of the skull and the dura mater, that is outside the dura or extradural, sometimes also called epidural. We sometimes use the term epidural hematoma. Okay. So next slide, you can move on to next slide. So basically, management is always medical and surgical. So if there is surgical indication, we do not wait, because most of the time we use the term called time is brain. Time is brain means if you want to save the brain, you must hurry. You must hurry. We don't have much time. So in this patient, you have to operate, you have to remove the blood within an hour. Within an hour, it is better to do. So before that, in between, you can manage the patient just like you manage any patient with basic life support or advanced trauma life support. You check for A, B, C, D, and E. That is airway, breathing, circulation. If everything is okay, check for C-spine. If the patient has fallen from height or met an accident, it is better to protect C-spine first by putting a heart color. Basically, it is better to put a Philadelphia heart color, which one is better than other heart color. So use the term Philadelphia heart color, and measure the GCS of the patient. If you see, if the patient has unequal pupil or one pupil is not reacting, then that indicates that there is some injury inside the brain. The ICP or intracranial pressure is increased. So it is the first thing that you can give is mannitol. We can give mannitol, which is available at 20%, and the dose of mannitol is 0.25 to 1 gram per kg. So do not hesitate to give mannitol. The indication of mannitol is pupillary dilatation or unequal pupil. So no need to give mannitol to each and every patient. You should not give. So it is actually a malpractice in most of the part of our country that a patient comes with head injury and mannitol is started. No, do not give mannitol until and unless it is indicated, and the indication of mannitol is unequal pupil. One pupil is reacting, other is not reacting, or the pupil that was reacting before is not reacting now. And if you see, the mannitol is available in 100 ml plastic bottle, and so it is 20%. So 100 ml contains 20 grams. But if the patient weight is 70 or 50, suppose 50 kgs, then this 20 gram is not an exact dose. So you may need to give 2.5 bottles. The patient needs 50 grams. 50 grams and one bottle, 100 ml bottle contains 20 grams. So you need to give good dose of mannitol, and normally the mannitol, you need to taper mannitol after 3 or 5 days. So the main management of this patient will be, you give mannitol because pupil is unequal. The patient may, because he had a bleeding from his scalp there and inside the skull. Nowadays, it is better to give tranexamic acid. So we give for any patient, not only head injury, for any patient that that approaches emergency department. If the patient arrives to emergency department with a history of trauma, chest trauma, abdominal trauma, or even head trauma, nowadays, because of this trial called crash trial, crash 2 and crash 3 trial that deals with use of tranexamic acid in trauma. So we give only 2 doses, 1 gram when the patient comes to the ER, and another second dose within 10 minutes, and the second dose we give within 8 hours. So only 2 doses of tranexamic acid, not more than that. So it is not good to practice like prescribing tranexamic acid TID or QID for 3 to 4 days. Just give 2 doses of tranexamic acid for any sort of trauma, and then the patient may be suffering from pain. So give good analgesics. You can give paracetamol, or you can give any morphine or fentanyl, good analgesics, and control of bleeding. If there is bleeding from the scalp, you can control bleeding. You can give, if the patient is vomiting, you can give antiemetics. I prefer to give perinom, that is metoclopramide. Someone, you can also give ondansetron, no problem. Okay, and in case of head injury, just remember one thing: we prefer to give normal saline only. So the patient, any patient with head injury will receive normal saline. Do not give 5% dextrose or DNS in patient with head injuries or any head problems like hemorrhagic stroke or ischemic stroke. So only normal saline in case of head injuries. So we can also give furosemide, Lasix, to decrease the ICP. So main thing is ICP. So what can be done to decrease ICP is oxygen. You can give oxygen if the patient is having hypoxia. If the patient is having hypotension, you need to increase blood pressure by giving normal saline. If not, if the blood pressure doesn't increase, you can also add noradrenaline or dopamine, no problem. So blood pressure should be maintained. And normally the head of the patient should not be kept flat. If you have gone through neurosurgical ICU, most of the or all patients except few are kept in the position, you can see Fowler's, low Fowler's position. Low Fowler means the head of the bed is elevated around 30 to 45 degrees. So 30 to 45 degree head elevation with the neutral position of the head will cause, is actually the first measure to decrease the ICP of the patient. That is through good venous drainage. So venous drainage should be good if you keep the patient at head of bed elevation of 30 degrees. So head of the bed is elevated 30 degrees and patient is kept supine. Okay. So okay. So we talk about analgesic, oxygen, antiemetics, head elevation, even sedation. If you can give good sedation is good. And if the patient is having GCS, like if the Glasgow coma scale is less than 9, that means the patient is in coma. So if the patient GCS is less than 9 or is less than equal to 8, then you need to intubate the patient. The first thing, as I talked before, is ABC. An airway should be managed. So any patient in coma, his airway should be managed. So any patient with GCS 8 or less than 8, intubate the patient. And you can titrate. So without stabilizing the patient in emergency department, do not take the patient for CT scan. So first stabilize the patient by doing the basic thing like ABCD. Okay. Okay. Let's move on to next slide. So here you can see the white hyperdense lesion is absent now, and you can see the bone is also broken. So we have broken the bone. We have done craniotomy. We use the term FTP. So FTP is nothing but it is the side fronto-temporoparietal. So we normally make a good flap, bone flap, that is fronto-temporoparietal craniotomy with evacuation of extradural hematoma under general anesthesia. So in case of white blood, now you can see there are a few black collections. Those are actually the fluid that are used for washing. It will disappear after a few days as the brain expands. But the good thing is there is no blood. Number one. Number two, now you can see the left ventricle that was missing in the previous slide, and there is no midline shift. Okay, let's move on to next slide. So this is something about head injuries. I think we learned one part of head injury, that is head injury means any trauma to scalp, skull, brain that can range from minor scalp laceration to brain injuries. So most important cause in Nepal are RTA, that is road traffic accident. We often use the term MVA, that is motor vehicle accident. FFH is fall from height, and physical assault or any violence. So these are the three main causes of head injuries. Okay, let's move on to next slide, please. So head injuries, they are classified into two types: primary and secondary head injuries. So primary head injuries are mechanical head injury. Actually, mechanical means due to whenever there is an accident or violence or assault, the head is being the force applied to head will cause direct injury. Those are like extradural hemorrhage, subdural hemorrhage, and even diffuse axonal injuries, contusions. These are all primary injuries. So this is due to mechanical force. When the head is banged or hit by something, so that causes primary injury to the head, which can't be treated, or we just can evacuate the blood, but there is no definitive treatment of primary except evacuation of hematomas. And secondary are non-mechanical. I think there's a mistake in this slide. Seema, you have written like intracranial hemorrhage. It's not hemorrhage. Hemorrhage are basically due to primary. Hemorrhage are primary insults. These hemorrhage comes under primary, whereas the secondary are something because of disrupted autoregulation of the brain, because of edema, because of increased ICP, or systemic cause of secondary head injuries like hypoxia, hypotension, hyperglycemia, even hypothermia. So these are the cause of secondary. So direct. So remember, primary means mechanical, due to mechanical force, RTA, physical assault, directly hit over the head, whereas secondary is not mechanical. Non-mechanical means because of oxygen, low blood pressure, high sugar, low temperature, edema, and all. Okay, so our main aim as a neurosurgeon would be to prevent as much as we can secondary injuries. So we operate the case if there are hematoma. So we cannot do much for primary thing, but when the patient made an accident or from the site of injury to the emergency department where there is a subspecialty of neurosurgery, that is more difficult part, because patient may be hypotensive, may be hypoxic during transfer of the patient. So as soon as the patient is brought to ER, it is better to check their SpO2. If it is low, give oxygen. If the patient is cyanosed, if the patient is comatose, intubate the patient. If the patient is hypotensive, give something, normal saline, or even noradrenaline to bring back the blood pressure. If the patient is hypoglycemic, treat hypoglycemia. If the patient is hyperglycemic, treat hyperglycemia, and keep the temperature normal. So patient may be hypothermic. You can increase the temperature by using some um, same thing, giving warm fluid and all. Okay, so next slide, please. So this is the new classification. Actually, if you see, uh, we must update ourselves with new things. So before, head injuries were classified on the basis of Glasgow Coma scale. So I think it's better to go to Glasgow Coma scale. Can you go to next slide, Seema? Okay. So this is the Glasgow Coma scale, which is used to know about the basic a patient of the neuro, any patient of neurosurgery. We want to know the scale, the coma scale, whether the patient is fully comatose or whether the patient is responsible or not. So this the three behaviors are taken into account. One is eye opening, the best eye opening. Another one is best verbal response, and last one is motor response, the best motor response. The total score is 15, and the minimum score is 3. And if the patient has GCS of 8 or less than 8, we use the term that is comatose. Patient is in coma. Okay. So in case of eye response, there are 4 scoring systems. If the patient is opening eyes spontaneously, so there's a patient who is in ER, and you go and see the patient is opening eye, then that we give E or eye response. We denote with the letter E is 4. But if the patient is not opening his or her eyes, and you go to the patient and you ask the patient, "Tai, open your eyes," then that is 3. So despite uh, your speech command, your verbal command, if the patient does not open his or her eye, then that you need to give some painful stimulus. So if you give a painful stimulus, and if the patient open his eyes, that score is 2. Okay. And despite giving painful stimulus, if the patient does not open his or her eyes, the score is 1. Similarly, in case of best verbal response, we have 5 points. If the patient is oriented to time, place, and person, then we give a score of 5. If the patient if the patient is not oriented to time, place, and person, that means the patient is confused. So if the patient is confused, that is, he's not oriented to time, place, and person, the score is 4. He produces words only, and those words are not grammatically uh, correct. He is only producing some words, then that is score is 3. Now the patient is not producing words, there are only sounds, then that is the score is 2. And if he or she is not producing, not there is no verbal response, then the score is 1. Similarly, we have motor response. So out of these 3, eye response, verbal response, and motor response is considered to be most definitive. It's better than other 2. If the patient obeys command, so most of the time the medical student will make a mistake, like the patient is moving his or her upper arms and lower arms, and then they give a score of 6. No, that is not correct. So if you need to ask the patient, you need to give command. Okay, open your eyes, or lift your upper limb or right hand, lift your right leg, lift your left leg. If the patient obeys your command, then the score is 6. But despite giving command, if the patient does not obey a command, you need to give a painful stimulus over his or her sternum or supraciliar nodes. Then you can, that is, if the patient can localize pain, that is score is 5. Patient tries to localize pain but does not reach there, that is score is 4. And this, if the patient does not respond, the score is 1. But the score 3 and 2 is a bit tricky, and it will be difficult for you to understand. So if the patient, after giving a painful stimulus, if the patient has abnormal flexion or decorticate posturing, means there is a flexion of both upper limb and extension of lower limb. So flexion of upper limb and extension of lower limb is actually, the score is given as 3 for decorticate posturing. And if the patient extends both upper and lower limb, that the score is 2. So that is decerebrate posturing. So this is the Glasgow Coma scale. So on the basis of Glasgow Coma scale, the head injuries are divided into various parts. Can you go back to the previous slide, Hiba? Okay, so this is the latest classification. Before, the mild, it is classified into minimal, mild, moderate, and severe. The previous classifications of severe head injury is similar to the this classification. That is, if the GCS is in between 3 to 8, it is severe. So, but the mild head injuries classification has been redefined, and there is a minimal also. So, if the patient has a history of head injury, so there is a history of head injury, the patient presents with GCS of 15, that is E4, E5, M6, and there is no history of loss of consciousness, there is no history of amnesia, then that is minimal head injury. Whereas if the patient has a GCS of 14, then that is mild head injury. Or if the patient has a GCS of 15 plus, either there is a loss of consciousness of less than 5 minutes, or there is impaired alertness or memory. So that also indicates GCS. If this happens, then that is mild head injury. So moderate head injury, GCS 9 to 13. Previously, 13 has been kept under mild head injury. Now the 13 is under moderate head injury, because it has been found in many studies that many patients with GCS 13 deteriorated. So it has been kept under moderate head injury. So GCS 9 to 13 is moderate head injury. If the patient had a history of loss of consciousness of more than 5 minutes, is moderate head injury. And if the patient has a focal neurological deficit, focal neurological deficit means if the patient has weakness of right side or left side or both upper and lower limbs, or hemiplegic, patient cannot see, patient cannot talk. So those are neurological deficits. If the patient has a history of focal neurological deficit, then that is also a moderate head injury. So don't, it's not just GCS of 9 to 13, but either 9 to 13 or loss of consciousness for 5 minutes or focal neurological deficit. You see, our patient, this patient has a GCS of 13, so that is moderate. This patient lost his consciousness for more than 5 minutes. That is also a moderate head injury. And this patient has hemiplegia, is left upper and lower limb, that is left extremity are weak. So that is also a focal neurological deficit. So it is a moderate head injury. So if GCS is less than 8, 8 or less than 8 is severe head injury. Now it is, if it is 3 or 4, it has been redefined as severe, also known as critical TBI or critical traumatic brain injury. So I think this is one of the most important questions that has been asked in your exams. So I think you need to memorize this new classification. So it is there in your new edition of Belly and Lab 2. Okay, next slide. Let's go move into next slide. Okay. So as I talked before, like, so this is something clinical. This is something much more clinical. This thing. Okay. Okay. So Pratima has written something like, we don't have clinical exposure, so it's related to clinical exposure. So if the patient, if you do not have clinical exposure, no need to worry. So these are something, the one thing that will guide you, is GCS, number one. Number two is localizing science. The most important is pupil. So if the patient comes with a history of RTA or physical assault and you see a pupil, then if the pupil is unequal, one pupil unequal, or both pupils dilated, not reacting, then you need to worry. So normally the pupil size is 3 to 4 mm, equal and reactive when torchlight is kept over the eye. So if it is not reactive, then there is some problem in the brain. So the pupil that dilates first on the side is the site of the injury in most of the time. That is actually true localizing science. So before the invent of CT scan, before CT scan was manufactured, how the doctors knew that the patient has head injury on the right side or left side? So this pupil and the hemiplegia guided us. This means if there is pupillary dilatation on the side of the injury, and if there is contralateral hemiplegia, So both of them are also called localizing sign, true localizing sign. Then there is the presence of hematoma on the site of the first pupillary dilatation. So this has been explained by Hutchinson, and this phenomenon, what happens? What happens to the pupil uh, in this patient? Again, if we think uh, in this patient, there are three pairs of eyes, pairs of eyes in the upper one. If you see the upper one, the pupil on the side of the injury contracts due to irritation of the oculomotor nerve. So if there is EGS, if there is any hematoma on left side, then that left side hematoma will expand, and that will compress the brain, and one of the part of the temporal lobe will be pushed inside towards the oculomotor nerve. So when oculomotor nerve is first irritated, the pupil will contract, and finally the same pupil will dilate later. So as the pupil on the side of the injury dilates, the other pupil starts constricting because of the pressure on the other oculomotor nerve, and finally both pupil will dilate. So if both pupil will dilate, it is also one of the sign of brain death. So we need to operate, or we can manage the patient either medically or surgically until until there is unilateral pupillary dilatation. If both pupil dilate, then there is high chance of mortality in this patient. We actually do not operate in most of the patients whose both pupil are dilated. So we can wait for we can in a patient present with unilateral pupillary dilatation, we will operate. If the CT scan shows the volume is higher and there is midline shift, we operate. Okay, so this is Hutchinson pupil. So Hutchinson pupil is because of it's actually because the oculomotor nerve is consists of two types of fibers. The outer one is parasympathetic and inner one is sympathetic. So when the outer parasympathetic is irritated, the pupil will constrict. But when sympathetic is irritated, the pupil will dilate later. Uh, will dilate later. So that is important. So most of the time we encounter patients whose pupil are dilated, because most of them they arrive late, not so early. Okay, so this is Hutchinson pupil. We can move on to the next slide. Okay, so if you remember the history of our patient, if you remember the first slide, the slide, normally in 80% of cases this should have happened. And go back. Okay, so normally in 80% of the patient this should have happened, not the one that had happened in our first slide. Seema, go back to the okay. Let's talk about this. So in this one, the true localizing sign. So 80% of the patient will present with this symptom. That means the patient will have history of fall or trauma. Patient will present with headache, vomiting, seizure, or bleeding from the scalp. A patient have some GCS, can be 8, can be 9. So we are not worried about that. The most important thing to focus here is weakness of limb. So if you see, previous patient had left side weakness, but in this patient had right side weakness. Assuming that both patient had same CT scan, that means if the CT scan of both patients showed left-sided extradural hematoma, then this should have been the this falls under the most of the case, that is 80%. If there is left EDS, then there should be right-sided weakness, not the one that we have discussed before. The one that we have discussed before falls under 20% of cases. That is false localizing sign. So true localizing signs means if there is hematoma or if there is stroke on one side, suppose left side, then there will be pupillary dilatation of left side, whereas there will be weakness of opposite side. That is called as contralateral hemiplegia. So that is contralateral hemiplegia. Whereas if there is trauma on left side, pupil is dilated or not reacting on left or right side, and there is ipsilateral hemiplegia or there is weakness of left side, then that is false localizing sign, which we had been discussing in this webinar, and that is not common. So common is same side pupillary dilatation or ipsilateral pupillary dilatation, and contralateral hemiplegia is true localizing sign. So why there is false localizing sign? So let's move on to next slide. As you remember, see my next slide. Okay, so if you remember anatomy, you can see number one shows corona radiata, and then we have internal. Number two is internal capsule, and finally the fibers will decussate in the medulla. So right side of the fibers, the corticospinal tract that comes from the corona radiata, that is one left or right, left side, will ultimately crosses the midline. So most of the fiber will cross the midline at number 4, that is actually medulla, to the left side. So right will cross to the left and left will cross to the right. So if there is a lesion, if there is a compression in between 2, 3, and 4 or above 4, if there is a compression of corticospinal tract above 4, there will be weakness of opposite side. So that happens normally in 80% of the cases. So 80% of the cases before the advent of CT scan, actually it has a history. I'll come to that later. So just remember this thing. So corticospinal tract, as it descends from the cortex of the brain, it decussates in medulla. So right fiber goes towards the left and left toward the right side. So if there is any injury before the decussation, before 4, then there will be contralateral hemiplegia. So in case of head injuries, the extradural hemorrhage, or you can see the part of the brain in between 2 and 3. The part of the brain in between the letter 2 and letter 3 is actually the temporal lobe. So this temporal lobe will compress the fibers number 3. So that will ultimately cause contralateral hemiplegia. So this happens in 80% of the cases. So what happens in that 20% of the cases? So let's move on to next slide. See my next slide, please. Okay, so next slide, our main topic is to inform you or give knowledge about something called Carhans-Notch phenomenon. For this, I think we need to go to next slide. Let's go to next slide. So, okay, this is for this you need to know about what is tentorium cerebelli. So tentorium cerebelli. So we know that brain is covered by dura mater. So both cerebral hemisphere and cerebellum is covered by dura mater. So in between two cerebral hemisphere, the dura mater will make a fold, and that is called falx. Similarly, in between cerebrum and cerebellum. So just remember, so in between cerebrum and cerebellum, the dura mater will make a fold, and that fold is called tentorium cerebelli. So what passes through the tentorium cerebelli is actually the brainstem. So brainstem will passes through the through that tentorium cerebelli. So let's move to a previous slide, please. So if you see in this picture, the lines that are present in the middle part is, we can see there is hematoma, the black one. Can you show the hematoma seema? The black one, the black thing is extradural hematoma that is present on the right side of your screen, but that's actually the left side, similar to our patient. And you can see the hematoma is compressing the uncus, the temporal lobe is compressing the corticospinal tract, and it causes contralateral hemiplegia. So yeah, just see the uncal herniation. Uncus is the part of the temporal lobe, and there is contralateral hemiplegia. Similarly, if you see the red arrow, because of this, can you show the tentorium? Can you show the tentorium on just below the red arrow? Below the red arrow, that one. Okay, that one. So that one is tentorium cerebelli. That one is nothing but the fold of dura mater covering the cerebrum and cerebellum. So if there is massive blood if there is massive amount of blood oozing, if there is because of trauma, if there is more than 30 or 40 ml, 50 ml of blood, then it will, the temporal lobe will not compress the will not compress the corticospinal tract of the same side. Instead, instead it will push. Instead, it will push the brainstem to the opposite side, and the brainstem will become and the brainstem will become pushed. Brainstem will become injured by the tentorium cerebelli of the opposite side. So that's why there will be injury over the at the tip of the corticospinal tract of the red arrow. You can see the red arrow. So arrowhead, you can see the arrowhead. So the corticospinal tract of the opposite corticospinal tract will get injured when the brain pushes, when the extradural or subdural hematoma pushes the brain, so that the descending pyramidal tract is injured uh, over the tentorial notch of the opposite side. So that's why there will be ipsilateral weakness of the limb, or we call it ipsilateral hemiplegia or Carnahan's notch phenomenon. So this happens in 20% of cases. So, and we do not see, we often it is very uncommon. So because of CT scan, because of advent of CT scan, we can now find out this false localizing sign. This is not true, but this is false localizing sign. So I think I have told you before, before CT scan was manufactured, we used to operate, the neurosurgeon used to operate depending upon these localizing signs. So right side hematoma, right pupil dilated, left side is hemiplegic. So they used to operate on right side. So after, but they couldn't find in 20% of the patients, they couldn't find, and they later, after doing autopsies and all, they found out that there was a notch on the brainstem, and that notch was caused by notching. That notching was caused by the tentorium, the A's of the tentorium, and because of that, there was ipsilateral hemiplegia, and that ipsilateral hemiplegia gave us a false impression about the site of the hematoma. That's why we use the term as false localizing signs, and that notch has been defined by Carnahan and his colleague as Carnahan's notch phenomenon. I hope I was able to make you understand. So we can go to the next slide, please. Okay, next one. So this was done by the Irish pathologist. He, in 1921, after doing an autopsy, he found why this happened, why there was ipsilateral hematoma in these 20% of the cases. So he found that it was because of this. So this is the brief history of Carnahan's notch. Okay, next slide, please. Okay, this is about complications of head injury. So there are many complications. The patient may throw seizures. So, and seizures, normally we classify post-traumatic seizures into two parts: early seizures and late. Early means if the patient had seizure within 7 days, that is early. 7 days of injury is early seizure, whereas after 7 days is um, known as the late post-traumatic seizures. Most of the time, the patient will ask you, like, patient came with head injury, so what is the chance of head injury later? So you may be able to tell them that if the patient is having severe head injury, then there is 10 to 15% chance of patient suffering from seizure. Even if mild head injury, there is 2% chance of seizure in 10 years of life. So you can say that the patient may have seizure. There's a 2%, 100, two people out of 100 may have seizure, even if the patient has mild head injury. So there is something written as communicating hydrocephalus. I hope hydrocephalus means dilatation of ventricles. I don't know how much you may have studied in first year and second year anatomy classes. So most of the patients with moderate to severe head injury may present with hydrocephalus later. Infection. So infection, if the patient is having closed head injury, there is less chance, no chance of infection. So we do not give antibiotic for patients who have closed head injury, but patient with open head injury, like or open fractures, open diffuse fractures, then we do give head injury. We do give antibiotics for a couple of days. Okay, vertigo. Vertigo is also one of the patient will complain if there is injury to the uh, um, temporal bone that contains the mastoid process, or or the parts of the inner ear. So that not only this, there are many complications actually. The patient may present with facial nerve palsy. Patient may have third nerve palsies. A patient may have uh, leakage of CSF from nose. We call it as CSF rhinorrhea, which is more common, and CSF from ear, that is CSF otorrhea. The patient may come with black eye or the panda eye shine. The patient may have uh, bluish discoloration of his mastoid. That is also one of the signs of base of skull fractures. So you need to, there are many complications. So most important one, if you see, are seizures, hydrocephalus infection, and expansion of hematoma. Sometimes we are treating the patient, those patients that doesn't come under that, those are not surgical candidates. Those are not surgical candidates. So most of the patient, 20 to 30% of patient may present with expansion of hematoma. So we need to keep this patient. So any patient with DCS of less than 15, you need to advise the patient to be admitted for observation in your hospital. Okay. Or if the patient has DCS of 15, CT scan is normal, then you may ask the patient to go home or discharge the patient from ER. But you need to consult his or her relative or friends who is accompanying him, that if the patient shows signs and symptoms of raised ICP like headache, vomiting, seizure, weakness of limb, bring him back to hospital for evaluation, further evaluations. Okay, next slide. Okay, this is okay. This our case was extradural, but sometimes you may come across hematomas that are larger in size. And if you look at the shape of the hematoma, the upper one, as I told you, the lesion is on the left side of the screen, so it is the right side. So the upper one, the shape of the hyperdensity, we do not use hematoma now. The hyperdensity, if you see on the right upper CT scan, is like the shape of the moon, concave or convex. So it is subdural hematoma. Even if you learn this one thing, I think that will be better for you. Whereas the lower one is biconvex in shape, so it is a extradural hematoma. So both of them have larger midline shape. If you see the septum or the septum pellucidum of the ventricle, they are pushed towards the opposite side, and it might be more than 5 mm. So you need to do you need to operate in this patient. So the upper slide is subdural hematoma. Since it is white in color, it is acute subdural. If it was black, if it was hypotense, we would have termed it as chronic subdural hematoma. So most of the time, the subdural hematoma is due to tearing of breathing veins, whereas the lower picture is most common cause. One of the most common cause is because of rupture of middle meningeal artery. High mortality, I think it is subdural, not extradural. So most of the patient with subdural hematoma dies. So and if the prognosis is better for extradural hematoma, mortality is high in subdural hematoma. So the difference between extradural and subdural hematoma is also asked in your final year exams when it comes to surgery. So next slide, please. So I think that's all for today. If you have any queries, you can ask me. I've tried my best to explain something. I hope you understood. So is there anything? Please do let me know.
Hello, sir. Am I audible, sir?
Yeah, you can.
Sir, sir, can I know the why tranexamic acid is used in epidural hematoma? It is contraindicated in brain injury like subarachnoid hemorrhage because it's got the cerebellar edema. I want to be clear in that. So,
No, it's not only extradural hematoma. Now, last year there was a big trial, the big trial on CRASH. It's known as CRASH trial. You can also search the internet, CRASH. So there are actually 3 CRASH trial, CRASH 1, CRASH 2, and CRASH 3. So the CRASH 1 trial, the first CRASH trial was the role of hydrocortisone or role of steroid in head injury. This trial was done in multi-country. So it has been found that there is no role of steroid in head injury. So we stopped using steroid in head injuries. The second trial, the second crash 2, it is called crash 2 trial. In crash 2 trial is actually the use of tranexamic acid in trauma, whereas crash 3 trial, the result of which came out, I think, in 2019, 2020, last year, and which says that the role of use of tranexamic acid, only 2 doses, can reduce the morbidity and mortality in this case, in expansion of hematoma. You said that in what about subarachnoid hemorrhage? I didn't understand. So I think there is no study. We don't have evidence. We don't have evidence whether tranexamic acid will be beneficial if you give it in SAH or not. We don't have evidence. So we need to talk about evidence, which has been done by multi-centric research, right? So we now have evidence that tranexamic acid is better if it is given earlier, less than 4 hours or 5 hours when the patient arrives to ER, in all cases of trauma, that is abdominal thoracic injury or even head injury. So those are crash 2 and crash 3. If you are interested, you can go and look those research. Though the difference is very minimal, but we do give priority to tranexamic acid. And there are many harmful effects. So we do not give for 3 or 4 days, just 2 doses in case of trauma. Okay. Anything?
If you have any questions, then please drop it in the chat box.
Okay, what Pratima, I think you it's clear, like clinical exposure. Okay, you don't need much clinical exposure because most of you will go to PHC. Some of you will go to PHC. So if the patient presents to under you and you are in charge or you are there, just look for the GCS, number 1. Look at the pupil and look at whether there is a hemiplegia or whether there is any neurological deficit or not. If the patient GCS is less than 13, and if you cannot manage the patient, it is better to refer the patient to higher centers, because even with GCS 13, most of the patients had intracranial hemorrhage, can be extradural subdural hemorrhage. Okay, Deepika, do we have a role of 3% normal saline? Okay, NaCl in head. Yeah. So actually, I prefer to give 3%. 3% NaCl is nowadays. It has been said that there is no role of mannitol. Mannitol is not used as the osmotic diuretics in case of head injury. The main role of mannitol is it increases the paucity of RBC, so it increases the flow of RBC. That's why we do give mannitol. But nowadays, mannitol is not preferred. We prefer to give hypertonic saline like 3% NaCl or 7.5% NaCl. Even 12% has been used in different countries, but in Nepal we use 3% NaCl. So don't use the term normal saline. 3% is hypertonic saline. 3% is not normal saline because it is not isotonic. 0.9% normal saline, 0.9% NaCl is normal saline because its osmolarity is similar to our serum osmolarity, whereas 3% NaCl is hypertonic. So we can give hypertonic. Just remember that you should not give it very fast because it may increase serum sodium higher and it may cause pontine demyelination. And I prefer to give 3% NaCl with Lasix, with furosemide, because it is concentrated NaCl, so the sodium will cause increase in preload, because sodium will pull water from the cells. It will decrease edema, but it will increase the preload. It will increase CVP. It may cause failure. It may cause heart failure or pulmonary edema. We do not need water, so we just give furosemide to flush that water out of our system. Okay, how much amount you should give? Okay, normally you can give 1 ml per kg body weight. So I prefer to give 100 ml. You need to give it slowly. I prefer to give 100 ml over 2 hours. So you can give 100 ml over 1 hour to 2 hours. So better to give slowly. And your target should be serum sodium. So your target should be the serum sodium should be around, you can keep it around 145 to 150 or even 155, depending upon. So it will actually guide us with the help of the CT scan. So if the CT scan shows edema despite doing decompressive hemicranectomy, then you need to be careful. Mannitol contraindication, one of the most important contraindication is renal failure. If the creatinine climbs up, it is better to stop mannitol. The creatinine, you need to see creatinine. Okay, any queries? You can ask me, no problem. And so regarding, I think dextrose, why it should not be given? You should ask like why dextrose is not given. So if you give dextrose, dextrose contains glucose and water. So since the metabolism is increased in head injury, the dextrose, the glucose part is absorbed, rapidly taken by the cells, and the remaining portion, that is water. So that will increase the edema. So it is not good to give any hypotonic saline, any hypotonic solutions like dextrose, even ringer lactate, we do not prefer to give. Okay. Okay, anything, question? Achal, you can ask me anything.
No, sir, I don't have any question.
I think I'm clear, right? Am I clear?
Yes, sir.
I know it's very difficult to, I tried my best, but I would prefer to talk in classroom. Okay.
So I think there are no more questions. So, okay, one question just came up.
So if you see intraventricular hemorrhage on imaging, do we operate immediately, give mannitol and observe? As I told you, like intraventricular, what is the indication of mannitol? So don't be confused. So indication of mannitol is pupillary reaction, change in the pupillary reactions. So do not misuse mannitol by giving mannitol to each and every patient, either with intraventricular hemorrhage. There is an intraventricular hemorrhage. So what is, if mannitol works as a osmotic diuretic, the main role of mannitol is to get rid of water that is present in the cell. That is, from cell it will bring, from interstitium or from the cell it will bring the water outside, that and that goes into vascular system. So if there is intraventricular hemorrhage, I don't think there is a role of mannitol. So whether we operate immediately, so operation depends upon whether that intraventricular blood had obstructed the CSF pathway or not. If the blood intraventricular hemorrhage has obstructed the CSF pathway, causing hydrocephalus, causing acute obstructive hydrocephalus, that might kill the patient right now. So we need to operate. So basically we do nothing. We just put a drain called external ventricular drain from inside the ventricle, and we try to release the CSF. Even we do not try to remove the blood from the ventricle. We try to bypass, since the CSF pathway is obstructed by blood, we try to bypass that CSF by putting a drain inside the brain. That is actually inside the ventricle. Okay. So Madhav has written, increasing the blood volume, does it increase the chance, risks of hemorrhage? What does that mean? I couldn't answer. Increasing the blood volume.
Does increasing the blood volume increases the risk of hemorrhage, sir? I guess you want to ask that.
Blood volume. So normally most of the patients will present with hypotension because of blood loss. Because if you say, so it's not about blood volume. The blood pressure should be normal, and the patient's volume should be, it is better to, the volume should be normal, not higher or low. So increasing, does it increase any chance to increase the risk of hemorrhage? So one thing I would like you to make it clear is, now we talked about hypotension. So most of the patient, whether it is hemorrhage, whether it is traumatic extradural or subdural hemorrhage or stroke, so most of the patients, they attend to ER with stroke. Stroke means ischemic stroke or hemorrhagic stroke, and their blood pressure is 170 by 100, 180 by 90 or 120. So do not worry. Actually, we should not lower the blood pressure in any neurosurgery patient. The higher the blood pressure, it is better. So the blood pressure, normally we are confused whether the hematoma, in case of stroke, whether the hematoma is due to increased blood pressure or uh, because of hematoma there is increase. So it's actually because of increased, because of blood inside the brain. Because of blood inside the brain, the blood pressure has increased, and that is a normal physiological mechanism. So you should not try to decrease the blood pressure. If the blood pressure is more than 190 or 200, you can give some antihypertensive like labetalol to decrease the blood pressure, but do not try to give uh, antihypertensive if the blood pressure is 160 or 70. So it is better to keep blood pressure 160 or 70 systolic for any neurosurgical patient, whether it is trauma or stroke, hemorrhagic or ischemic. So do not worry about that. Okay. Okay. So anything?
So I think there are no more questions. So once again, I would like to thank Shabal sir for the very simplified and detailed explanation of today's topic. And now I would like to request Ayusha to kindly share a small token of love which we have prepared for you.
Okay. Thank you very much. Thank you for listening.
So we'd like to hear a few words about today's program and the Grey Medicos from you.
I think it's a good initiative. I didn't know much about that. And thank you, Atul, for inviting me to talk for this talk. I think it's good. I think if there is a good team from each and every institute, then you can invite uh, the specialist to talk about, so that you can have knowledge, and you will know each and every doctors um, from their institute, and sharing. I think it's good to share information and knowledge from one institute to other, and you guys have done a good job by creating this sort of platform. I think most of the doctors from relevant institutes should know about what you are doing, right? And you must invite those who are, and those who are interested may join you, and they will share their knowledge and experience. Thank you very much.
Thank you so much, sir, for those words. It really means a lot and it has inspired us. And I think Seema, we have lost Dr. Seema, but we have prepared a token of love for her as well. And we'll share it to her afterwards via mail. Now, I think I want to thank and congratulate all the working team members of the Grey Medicos, Ayusha Bandari, Robbie Bashyal, Ashok Pandey, Sheena Ronyar, Subin Regmi, Sujan Sharma, Umnath Bhatrai, Ram Aryal, Roshan Bhatrai,